So thank you to Elvin and Lauren for inviting me to be here and also all the great talks and speakers we've had today. I'm going to present a study that we did kind of using an application of regression discontinuity, which I think is a method that is useful in the implementation science armamentarium. So kind of an applied example of what we've talked about today.
Try the mouse.
Mouse, okay. There we go, okay. So the globe is rapidly transitioning towards treat-all based on the results of 3 major randomized controlled trials. The HBTN 052, which showed that ART reduces transmission, and then Insight, START, and Temprano, which showed that you have improved patient outcomes with immediate versus deferred treatment. Kind of as a general rule, RCTs try to establish the biological effects of ART, which kind of amounts to the efficacy. But there's also another related but different question about the real-world effects of adopting this policy, which still remain unknown. That's sort of the effectiveness of rolling out ART. The reason RCTs don't necessarily answer this question is because the ultimate public health impact of rolling out ART not only depends on the efficacy of the drugs, but also on the behaviors of patients when you're rolling this out, and then also on the capacity of health systems to absorb a new influx of patients. So benefits of expanding ART on patient behavior, you have the direct effects on ART initiation, but they could be an indirect behavioral related to retention. We've talked about community mobilization, social networks. All of those things could change with a policy. You also have negative spillover effects that could happen when you roll these out, unintended effects, which include increased congestion at the clinic. You could crowd out sicker patients, which would be unintended. So one potential solution to kind of understanding this effectiveness question are quasi-experimental designs, which are basically study designs that attempt to approximate experimental conditions using real-world data. Examples of these include regression discontinuity, instrumental variables, interrupted time series, and then I think sometimes difference in differences and fixed effects studies are also included in this. I think a main, one of the key benefits of quasi-experimental designs is that you get to study the interventions delivered through real-life systems in everyday contexts. So you get to assess the effectiveness, which is the effect of actually expanding ART versus the biological effect of ART. In RCTs, in attempting to assess for the biological effect, they frequently control for confounding by carefully selecting patients, carefully selecting sites, and then also essentially interfering with the intervention process through this tightly controlled environment. Thus, by studying interventions in their real-life systems, you potentially can generate evidence with high rigor and relevance, but this has to be done in the right setting. And the right setting means that to establish rigor, you do have to be able to meet the underlying assumptions of the study design, which is not necessarily easy. And then also you have to have the right situation where you can answer the question that you really want to be answering to create the relevance. So we were kind of presented with one of those situations from some of our work in Zambia. Zambia now has adopted universal treatment, but prior to this, it had changed its HIV treatment guidelines on April 1st, 2014, to expand ART eligibility to include patients with a CD4 between 350 and 500, and then also all pregnant and breastfeeding women under option B+. And we were conducting a study at that time. So we leveraged this 2014 guideline change in a quasi-experimental study design to assess the effects of this expansion change, and then also kind of shed light onto what might be expected when Zambia, with the expansion to treat all in Zambia. So the study objectives were, 1, to estimate the real-world effects of expanding treatment eligibility on 1, ART initiation, and 2, retention and care in the general clinic population using a regression discontinuity design. And then we also wanted to quantify the effect of actually initiating ART in routine care on retention, and we used an instrumental variable design for this. Our hypothesis was that expanding ART eligibility will lead to both improvements in ART initiation and retention and care, but also without crowding out sicker patients. So a little bit more about the methods. So our study population were ART naive patients greater than 15 years old. These were patients who newly enrolled before and after this change in Zambia's treatment guidelines, so between April 1st, 2013 to November 1st, 2014. And this we collected data from 64 clinics that were supported by the Center for Infectious Disease Research in Zambia, or CIDRS, which was in Lusaka, eastern, western, and southern provinces of Zambia. And our measurements came from the EMR system used in routine HIV care in Zambia, which is called Smart Care. For this system, providers essentially, they manually fill out clinical forms during the encounter, and then data technicians subsequently enter this into the electronic medical database. So we use a regression discontinuity design for the first part of this study. These study designs in general can be used when treatment is assigned by a threshold that is essentially arbitrary, which could be in the case of CD4 thresholds of, a threshold of 350 compared to a threshold of 349 or 351, or I think, Thomas brought up today, when eligibility criteria for a trial is based on a sort of an arbitrary gestational cutoff. You could look at just before and after that cutoff. Then in that setting, you compare patients just above and below that threshold, which is sometimes called local because you're looking at a small window. And the assumption is that since the cutoff is essentially arbitrary, you assume that patients are similar on both unmeasured and unmeasured characteristics, and also assume that the potential outcomes will be continuous around that threshold. Thus, exposure is as if it was random. And that's called the continuity assumption for regression discontinuity designs. So for our study, we use regression discontinuity to estimate the effects of implementing new ART guidelines. And we compare patients enrolling just before and after this guideline change. So our threshold was a date. Our main outcomes were 1, ART initiation by 3 months, 2, retention and care at 6 months, which we define as having made at least one visit between 3 and 9 months post-enrollment. And then we also looked at a composite outcome of having started ART at 3 months and still being in care at 6 months. For the model that we used a local modified Poisson regression with robust variances to then estimate the risk difference for each of these outcomes at the time of the guidelines were rolled out. We did exclude patients enrolling 90 days prior to the date of guideline implementation to prevent any bias from crossover, where pre-guidelines patients have their outcomes defined after exposure to the guideline. And then we also excluded patients 60 days after guideline implementation to account for a transition period during gradual uptake of the new guideline. We also did conduct various sensitivity analyses, such as wearing the kind of bandwidth, the time around the cutoff, and the length of the transition period to ensure that these results were robust to some of these specifications that we made, which I'm not going to actually go through in the presentation. So the next thing that we did was we sought to estimate the effect of actually initiating ART in routine care on subsequent retention, and we leveraged the RD design to then use implementation of these new guidelines as an instrumental variable to actually do that. So the main reason to do this is that in observational settings, there are going to be many measured and unmeasured common causes or confounders of ART initiation and retention in care. Stigma could be one. Patients' beliefs about healthcare could affect them starting ART, but then also whether they subsequently are retained. So that makes, just using traditional methods for observational analysis somewhat limited in getting a robust result. But IVs allow you to obtain unbiased estimates even in the setting of unmeasured confounding between the treatment, which is ART initiation, and the outcome, retention and care, under a few certain assumptions which are quite plausible in our setting. One is the instrument, in this case, implementation of guidelines, is associated with the treatment, which is ART initiation. 2, then there are no common causes of the instrument and the outcome, which is also plausible because nothing really affected the implementation of the guidelines that would also affect retention on a wider scale in the country. And 3, the instrument affects the outcome only through its effect on the treatment. So the only reason the guidelines would affect retention is through more ART initiation. And in this situation, we can then estimate the effect of ART initiation on retention and care, specifically for those patients who initiated ART in response to the change in guidelines, which is also called the local average treatment effect. For our analysis, we also defined 3 patient subgroups, which were defined irrespective of their actual date of enrollment, but whether they would have been eligible or not based on the different criteria. So our first subgroup were always eligible patients who would have been eligible by the 2010 guidelines at the time of enrollment. So these were patients who had a CD4 below 350, had a WHO stage of 3 or 4, or had active TB. Then we had a second subgroup, these newly eligible patients who would have been eligible by the 2014 guidelines when they enrolled, but not the 2010 guidelines. So these were patients with the CD4 between 350 and 500, and also pregnant and breastfeeding women. And then we had the not yet eligible subgroup who were not eligible by either the 2010 or 2014 guidelines. So these are patients with a CD4 greater than 500. So moving on to the results. So there were about 35,000 patients who newly enrolled during this period, and 23,000 were ultimately included in our RD analysis. Kind of looking at the proportion enrolling before and after the guidelines, it's quite balanced. Looking at patient characteristics, I think a couple of things to notice about when patients were enrolling. One, they had a median CD4 of 268, and even during this period, about 70% of patients were still enrolling when they were kind of in that always eligible group, so basically had more advanced disease at the time of enrollment. This is a very dense slide, but the main takeaway is that within each patient subgroup, patients enrolling prior to the change in guidelines were quite similar to those who enrolled afterwards, which helps to verify one of the underlying assumptions of the RD analysis. This slide also helps to kind of verify some of the assumptions. Here we see the number of new patients enrolling in orange, and also the weekly number of clinic visits in blue. As you can see, these are continuous at the time of that the guidelines were rolled out, and remain essentially unchanged before and after the guidelines were rolled out. So this kind of also helps to verify the continuity assumption at the threshold of this analysis. So these first set of slides show the results from the RED analysis in the overall patient population. The x-axis shows the time since the guidelines were rolled out, with the dotted line representing the date of implementation. And then the y-axis represents the percent of patients with the outcome. In this case, it was percent with ART initiation at 3 months. So as you can see, implementing the new guidelines led to a 13.6% increase in ART initiation at 3 months in the overall clinic population, a 4.1% increase in retention and care, again in the overall clinic population, and then implementing the new guidelines also led to an 11% increase in the percent of patients who had both initiated ART in 3 months but were still in care at 6 months. Kind of looking at the subgroups, so the always eligible subgroup, the patients who were kind of sickest when they came in with the lowest CD4 counts, we found a 6% increase in ART initiation in this group, really no effect on retention, and a 4.6% increase in the number of patients in care and on ART at 6 months. Looking at the newly eligible subgroups, so these were also the ones that were primarily targeted by these guidelines. You see a 44% increase in ART initiation by 3 months with the rollout of the new guidelines, 14% increase in retention and care, and a 36% increase in those in care and on ART at 6 months. And then lastly, we're looking at those patients not yet eligible, the ones with the CD4 above 500 essentially. We actually did see a bit of an increase in ART initiation in this group as well, a 13% increase. No effect on retention, and 10.8% increase in those in care and on ART. So this last slide shows the effects of the instrumental variable analysis, which are essentially measuring the effect of ART initiation on retention and care in a routine setting. So in our group, actually initiating ART led to a 37.9% increase in retention and care. And this translates to needing to start 2.6 patients on ART to prevent one episode of loss to follow-up. So there are several limitations to this study. One, kind of based on the assumptions of the regression discontinuity and kind of what these results means. Strictly speaking, they're only supposed to be generalizable to the current care setting where we study this. So I think definitely relevant for interpreting these now. They might not apply to linkage to care or initiation under different circumstances, which we're already thinking about. We're talking about home-based testing and linkage, We're talking about same-day start. These things were not happening at that time, so some of that could affect the interpretation, the generalizability of these results to a different setting. We weren't able to assess viral suppression at this time. Those were not routinely collected in Zambia when we did this. They are now, so that would be a opportunity for a future study. But though retention is still an imperfect proxy for virologic outcomes. We did exclude patients who were enrolling immediately before or after the guidelines changed. Though in our sensitivity analyses, we sort of varied the specifications to ensure that our results were robust to the model specifications. We also kind of did, in other analysis, we didn't find any evidence of any short-term secular trends that would affect, that this decision would introduce bias. And then we did use routine data, which I think there's been a lot of discussion about today. So there are limitations to that. So there's potential for misclassification of the subgroup or an outcome, but I think there's not really a reason to believe that that should be differential across the before and after time. So in conclusion, based on these results, we found that expanding ART eligibility led to positive effects in the overall population with a 13.6% increase in ART initiation, 4.1% increase in retention and care, and a 10.8% increase in the percentage of patients in care and on ART at 6 months. These effects were primarily driven by improvements in ART initiation and retention in the newly eligible patients, but we still also did see small increases in ART initiation in those always eligible and not yet eligible. And kind of like trying to interpret that result with some kind of preliminary sort of ad hoc, discussion, we think this potentially is due to sort of the overall expansion of the ART supply and sort of an informal loosening of eligibility criteria. I mean, at this point, the benefits of ART were well known, so a lot of providers were probably offering ART even though patients were not yet officially eligible. And I think kind of looking back at the slides, even before the guidelines, a certain percentage of patients who weren't eligible were still getting started. Second, initiating ART in routine care does increase retention by 37.9%. I think this is an interesting finding because when they looked at the kind of Insight Start Temprano, they were rigorously following patients and they all had 90% retentions kind of in both, plus over 90% retentions in both arms. But here this is another benefit which can improve outcomes. And lastly, we're still seeing that 70% of patients still present at more advanced stage. 25% of the eligible patients are still not initiating ART at 3 months, and 40% are not in care and on ART at 6 months. So still a ways to go in other capacities. So I think some implications of this, we believe that we'll probably see similar improvements in the number of patients on ART and retention and care as we move into treat all, but I think importantly, without seeing associated negative spillover effects. I think, nevertheless, depending on the underlying population, the overall effects of expanding ART might still be modest, and so substantial efforts are still needed to really improve early diagnosis and linkage to care, and then also keeping those patients retained. It's not as simply as I think, just expanding ART to all obviously solves these problems. We do still need further evidence on the real world effects of treat all, the impact on viral suppression, better understanding of those that never start ART or quickly drop off. And then, as we've kind of talked about, who are those patients who are not going to benefit from eligibility alone? There are a lot, but who are those patients who don't, and what do we do for those patients? And then I think kind of for today, quasi-experimental designs are quite a powerful tool in the implementation science armamentarium for assessing effectiveness and really understanding the effect of real-world implementation. But you need to have the right setting to do it well. Thank you.